Hi, this is Jessica Dillard-Wright, and this is my final presentation for NURS 8100, Diseases of the Heart, Blood Vessels, and Lungs. Our learning objectives for today include that learners will be able to describe key disease processes of the heart, blood vessels, and lungs, including atherosclerosis, coronary heart disease or CHD, complications of CHD, hypertension, and selected respiratory disorders. Learners will understand nutritional needs, challenges, and management specific to these processes, while also being able to describe lifestyle modifications to improve the above disease processes and maintain health. Cardiovascular diseases are the leading cause of death in the United States, and this process starts with atherosclerosis. It's kicked off by the accumulation of lipoproteins into fatty plaques, which build up on vessel walls over time, damaging vessel walls and interfering with blood flow. When flow is obstructed, tissue injury and death occurs, and this is where we have complications. This can have catastrophic consequences depending on the site. We'll start by talking about atherosclerosis and the lipoproteins that cause atherosclerotic plaques. This will segue into a discussion of the risk factors for and interventions to manage and prevent CHD. From there, we'll talk about a related disorder, hypertension, and including dietary and lifestyle interventions to prevent and slow disease progression. We'll also review complications arising from cardiovascular disease and briefly review the nutritional management of pulmonary disease processes. I encourage you to email me your questions at any time. I may not be available to you face-to-face, but I can certainly answer questions if you send them to me. So let's start with atherosclerosis. Atherosclerosis is an inflammatory disease of the blood vessels that's systemic and progressive. Fibrous plaques develop after injury to the intima of the blood vessel. This wall back here, this is the sort of representing the intima. Over time, these plaques evolve and grow, eventually causing turbulent blood flow, ischemia, and injury to the surrounding tissue. As you can see, we have like significant narrowing of the space for blood to flow through as this plaque evolves. As these plaques evolve, they may eventually cause turbulent blood flow, ischemia, and injury to the surrounding tissue. Possible causes that sort of launch this process include smoking. And let's just put it out there. Smoking never ends well for anyone, so let's just encourage all of our patients to quit doing it. Hypertension, diabetes, increased serum cholesterol, oxidative stress, and infection, among others. Over time, the plaque may cause the occlusion of blood vessels, leading to tissue infarction, which is also tissue death. This is often linked to serum, very low density, and low density lipoprotein levels. Atherosclerosis is not limited to the peripheral vasculature or the small blood vessels of the body, but it can spread to include those in the heart and the brain. So let's take a moment to think about lipoproteins. Lipoproteins have kind of a bad rap. But they do serve important functions in our body. For example, chylomicrons, large and low density, transport exogenous triglycerides from our diet to the tissue for use, while high density lipoproteins, good cholesterol, is small and dense and plays an important role in cholesterol catabolism. Please pause the presentation here and review the different types of lipoprotein listed in the table. Maintenance of these lipoprotein levels within normal limits may alter the risk for coronary heart disease and cardiovascular disease. So as you can see, serum levels in various lipids in our bodies contribute to the risk of coronary heart disease and cardiovascular disease. This connects the disease process of atherosclerosis to problems in the heart. Having a high LDL, bad cholesterol, and low HDL, good cholesterol, contributes to the risk for cardiovascular disease. So these are the lipid risk factors, but what about the non-lipid risk factors? Well, these break down into two categories, modifiable and non-modifiable. Before we launch into our discussion of modifiable and non-modifiable risk factors, take a moment to ask yourself, what does it mean that a risk factor is modifiable? If you said non-modifiable risk factors are those things we cannot change, while modifiable risk factors we may have some control over, you're right. So this is definitely not an exhaustive list of the modifiable risk factors for CVD and CHD, but we can see that smoking, obesity, and diabetes compound the risk presented by hyperlipidemia. Hypertension, discussed a bit in a future slide, may also be a risk factor and contributor to cardiovascular disease. So those non-modifiable risk factors are things that we don't have any way to change, and those include age, sex, and family history and heredity. At this point, we don't have a way to change genetics, but maybe one day in the future we will. So, what are the major complications we're looking to prevent? Things like death of heart and brain tissue, as occurs in myocardial infarction and stroke. So take a minute and think to yourself, what is ischemia? What is infarction? Well, ischemia is when you have injury to tissue because of low oxygen supply, while infarction is when that ischemia, that deprivation of oxygen, leads to tissue death. So when you have a myocardial infarction, you have death of the cardiac tissue. And we can see here, this is the rendering of the heart. And we have this box popped out here. And we can see the development of atherosclerotic plaques, kind of constricting blood flow through the coronary arteries. If these plaques rupture, if there is a clot that kind of makes its way through here, it might get hung up on the sticky tissue, the sticky plaques, and cause an occlusion, which can lead to ischemia and over time infarction. Cardiac tissue dies as a result of this impaired blood flow and decreased oxygenation. So the primary intervention when we're thinking about what we're going to need to do for patients who are undergoing an acute myocardial infarction, we need them to engage in cardiac rest. So a similar process can actually happen in your brain. We see here that we have the blood flow in the brain, and then we can also see here that we have the development of fatty plaques. And when the blood vessels in your brain become occluded, the brain tissue dies, causing an infarction. What's that again? Oh, right, tissue death. So these can be precipitated by atherosclerotic changes and complications like thrombosis and embolism, which accounts, and this type of stroke accounts for 70 to 80% of all strokes. These are known as ischemic strokes. Another less common type of stroke is a hemorrhagic stroke, which may be caused by hypertension. Area of injuries cause specific problems which may impact nutrition. Injury to the right may cause problems with feeding, swallowing, and speech, while left-sided strokes may cause sight and hearing loss, which can lead to neglect of food on the plate. Patients with strokes, no matter the type of stroke, often experience dysphagia or difficulty swallowing, which presents unique nutritional challenges. These types of events that we've just covered that occur in the heart and the brain can also occur in the peripheral vasculature. Especially the limbs. And when we're thinking about that, cigarette smoking is an especially important risk factor for the development of peripheral vascular disease. So this next slide outlines the lifestyle nutrition recommendations for reduction of coronary heart disease risk. So what are we going to do when the lipoproteins get out of control to prevent complications? What do you think? Well, therapeutic lifestyle changes may be all the intervention a person needs to do. So that can include limiting LDL raising nutrients, so keeping your saturated fat levels less than 7% of your total energy intake, limiting dietary cholesterol intake to less than 200 milligrams per day. You can also think about adding in some supplementation to decrease LDL, so not just limiting nutrition, limiting LDL raising nutrients, but also adding things that actively lower LDL, like plant stanols and soluble fiber. Maintenance of a desirable BMI, physical activity to expend at least 200 kilocalories per day, avoiding trans fat, and limiting sodium are all key in reducing the risk for coronary heart disease. So take a moment and review the nutritional composition then that this would equate to. We can see that polyunsaturated fat should constitute less than 10% of total energy intake, monounsaturated fat should be less than 20% of total intake, and total fat should be less than 25 to 35%. Carbohydrates should be about 50 to 60% of one's total intake, and dietary fiber should be 20 to 30 grams per day. And protein should amount to about 15% of total energy intake. So what do we do when these interventions don't work? Well, it may be necessary at that point to introduce drug therapy. However, therapeutic lifestyle changes should be implemented in tandem with drug regimens, no matter what, to optimize health outcomes. Other elements to consider are increasing weight control, increased physical activity, and both of these things work to lower risk by lowering LDL and raising HDL. Managing metabolic syndrome can also further reduce the risk for vascular disease, cardiac disease, and stroke. Before we foray into the solution to the problems that we've already talked about, let's take a brief detour into hypertension. Hypertension, high blood pressure, is a major risk factor in heart disease, stroke, heart failure, and kidney disease. The next few slides are interventions for both atherosclerosis and hypertension. The two often occur in tandem, and the recommendations for management apply to both, which is why we'll talk briefly about hypertension now. Blood pressure is divided into two different numbers. We have the systolic pressure, the top higher number that represents the contraction of the cardiac tissue, cardiac muscle, and then the diastolic pressure, which is like the filling stage of the cardiac cycle. Pause here and think about what the factors are that may elevate blood pressure. Factors that may elevate BP include pumping pressure of the heart to move blood around the body, and then resistance from blood vessels. And what are the things that are going to cause resistance from the blood vessels? If you said atherosclerosis, you might be right. Resistance from blood vessels may be caused by abnormal thickening and stiffening of the walls. If you take a minute and review this chart, you can see the classifications of blood pressure here. We would like people to be in that sweet spot normal range below 120/80. Ideally, we would prevent the development of hypertension altogether through healthy diet and adequate physical exercise. However, when blood pressure rises, several nutritional interventions may help, and at some points it may be appropriate to add in drug therapy. Pause this presentation here and review the categories of hypertension, and then we'll pick it back up with the next slide. Okay, the U.S. Department of Health and Human Services recommends the DASH, or dietary approaches to stop hypertension, for heart health and improving hypertension. So the goal here is primarily to limit sweets and fat while loading up on fruits and vegetables. Breads and cereals should ideally be whole grain, while meats and proteins should be lean cuts, and you should avoid processed and organ meats. In addition to the DASH diet, you really need to make physical activity part of your routine. A sedentary lifestyle contributes to a decline in heart health and vascular health. Ideally, adults should get about 30 minutes of moderate exercise 5 times a week, or at least 25 minutes of vigorous exercise 3 days a week. And in addition to that moderate or vigorous exercise, some moderate to high intensity muscle strengthening activity for heart health. No, this is just for heart health. This isn't for weight loss, and this isn't necessarily going to be enough to help control blood pressure. For lowering blood pressure and cholesterol, a minimum of 40 minutes of moderate to vigorous exercise 3 to 4 days per week is recommended. So let's jump back to the heart for a minute. After MI, or in the setting of severe hypertension and pervasive atherosclerosis, the weakening of the myocardium may lead to congestive heart failure. Okay, this is a chronic heart disease that sort of occurs as the heart tissue is more damaged and cardiac output declines. As cardiac output declines, it alters fluid balance. So congestive heart failure can lead to fluid retention and pulmonary edema. And this alters the normal mechanisms of fluid balance. And this is the result of kind of an altered hormone balance, specifically the aldosterone and ADH systems. Both are triggered by impaired renal blood flow, which results in increased fluid retention and subsequent further exacerbation of edema. This impaired circulation also results in decreased cell metabolism, which causes the accumulation of intracellular potassium. The concentration gradient created here leads to the accumulation of extracellular sodium concentrations, and that, then water follows sodium, so it further exacerbates water retention still. So for these patients, sodium should be restricted to 2 grams per day. Fluids may be restricted to as little as 1,500 cc's a day. And really a lot of thought should be given to meal size and the effort of consumption of a given food, as physical effort may cause fatigue and distress and malnutrition. Alcohol should be limited or eliminated entirely. So cardiac cachexia occurs when heart failure leads to extreme malnutrition. Nutrition therapy here should be focused on restoration of heart and lung function, and energy requirements are going to be increased. The extent will depend on the severity of the malnutrition, but it may be as much as 30 to 50% more than basal needs. Protein should be at least 1 to 1.5 grams per kilo, and sodium restriction is going to be further escalated to 1 to 2 grams, while fluid restriction will be even more austere at 1 liter to 1.5 liters per day. Okay, so let's move from the heart to the lungs. Congestive heart failure can cause respiratory distress, and this has implications for nutrition. But we also have other common causes of pulmonary disease, including COPD, pneumonia, and tuberculosis. The symptoms may be similar: cough, respiratory distress, shortness of breath, activity intolerance, but the medical management is going to depend on the causative underlying process. So let's talk about the nutritional management of COPD, pneumonia, and TB. These disease processes result in increased nutritional demands secondary to increased energy requirements. A patient with COPD will require balanced proteins at 15 to 20% and carbs at 40 to 60%, and fats at 30 to 45%, but they may experience a lot of fatigue associated with meal preparation and even eating the meal itself. COPD is chronic and progressive, and chronic malnutrition is common. COPD is also often complicated with other cardiovascular disease processes that may have specific dietary requirements that will also need to be added into your consideration. Pneumonia is typically an acute and fairly shortened duration disease process. The patient with pneumonia will require adequate hydration of 3 to 3.5 liters per day, unless that's contraindicated, like if they have pneumonia and also heart failure. Small, frequent meals may be better tolerated, same with COPD or any respiratory disorder that leads to shortness of breath with effort. Consider adding in a multivitamin and minerals and fiber to beat constipation. Fruit juice may be well tolerated and will provide necessary fluid and potassium. With tuberculosis, a longer-term infection, though not lifelong like COPD, the objective is going to be to avoid weight loss. Febrile patients, no matter the pathogen, will be hypermetabolic and require additional protein and kilocalories as well as vitamin and mineral support. So I would love to hear from you. If you have questions, please let me know. The references for today's presentation include Billings and Halstead's Teaching and Nursing, a Guide for Faculty, as a reference for best practice, and the content from today's presentation came from Roth's chapter on diseases of the heart, blood vessels, and lungs in Williams' Essentials of Nutrition. And I'll leave you with a test question here. The nutritionist knows that atherosclerosis may be managed with lifestyle modifications and dietary changes. Which of the following is an appropriate intervention for the patient with atherosclerosis? A, recommend reduced intake of saturated fats and cholesterol, weight reduction, and increased physical activity. B, recommend intensive HDL lowering while encouraging increase in serum LDL. C, recommend reduced intake of saturated fat and cholesterol, weight reduction, and decreased physical activity. And D, ensure that the patient can swallow without difficulty because their disease process may result in dysphagia. If you said A, you're right. Good job. Thanks.